Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ardelyx.
Welcome to this program, which is called Integrating Novel Therapies for Hyperphosphatemia and Dialysis-Dependent Chronic Kidney Disease. I'm Dr. Ellie Kalapouris. I'm professor of clinical medicine and the clinical chief of the Renal Electrolyte Division at the University of Pennsylvania School of Medicine. And I'm joined today by two very distinguished faculty and colleagues, Dr. Pablo E. Pergola and Dr. Stuart Sprague. Welcome, everyone. We're going to review the current challenges with hyperphosphatemia in dialysis-dependent chronic kidney disease. We've known for a very long time that there's a mortality risk by serum phosphorus level in patients on hemodialysis. The two national cohorts that demonstrated that the risk of mortality increases in chronic kidney disease for each increase of phosphorus by 1 milligram per deciliter. And that's really a very important observation because you see on this slide, the mortality risk is a U-shaped curve. The higher the phosphorus, the higher the mortality risk. And as I said, it's almost 18% for every 1 milligram phosphorus elevation above normal. When you look at the association between phosphorus and mortality in hemodialysis across age groups, you see that there's an association across all age groups, but particularly high in the elderly, 70 to 75 years old, when there's a very high association, and those patients benefit from phosphate control the most. The burden of hyperphosphatemia and dialysis-dependent CKD is high. We've known this for a very long time, and it's been defined in a construct called chronic kidney disease mineral and bone disorder, or CKD-MBD. That construct has been refined in 2023, 2024, and 2025 to include the clinical observations that we see with CKD-MBD, which is joint and bone pain, fractures, vascular calcifications, and nodular calcium deposits. We have to close the gaps in hyperphosphatemia management really to regulate the clinical manifestations of CKD-MBD. And much progress has been made in managing high phosphorus and preventing major complications like nodular calcium deposits and calciphylaxis. But we're still talking about the same issues 20 years later. And clinical trials for phosphate lowering agents typically include mortality as the primary endpoint, and we really have not seen that. But factors like quality of life indicators, joint pain, and constipation really should be prioritized. Pablo and Stuart, you've been colleagues in treating patients for chronic kidney disease for a very long time. What is your comment about how we can close these gaps and your observations and management?
Well, I do think we really need to focus on the patients and not just look at overall mortality per se, but how patients do overall. Compliance is obviously an issue. Tolerance is obviously an issue. One of the things I've noticed in taking care of patients for a long time is you go there and you tell them their phosphate's high and you keep beating on them. So they think, well, why should I even take these medications? They're not working. So to me, I think it's really trying to refocus on getting something. Pablo, what's your thoughts?
I totally agree with that, and we think we more than ever need to be patient centric. If we listen to the patient and their frustrations, I think we're going to gain a lot and helping to manage this chronic problem, and also understanding that we're pressured to chase a number sometimes in the clinics, and that the patient being less than 5.5 milligram this month doesn't really mean they're going to be there next month. So very intermittent management. And so we need to look long term and just look back and think forward when we're managing phosphorus to make sure we manage patients consistently to our goals.
So, this is a fantastic intro into a discussion of current management strategies for hyperphosphatemia and dialysis dependent chronic kidney disease. We'll lead off with the current guidelines for hyperphosphatemia control. And as you both mentioned, the clinical practice guidelines really focus on a number rather than the patient and how the patient feels. And the clinical practice guidelines recommend lowering elevated phosphate levels towards the normal range. Both the National Kidney Foundation KDOKI and the International KDIGO Improving Global Outcomes focus on a number. The KDOKI really guidelines recommend that patients treated with dialysis that their serum phosphorus level should be maintained between 3.5 to 5.5. The KDIGO guidelines are a little more stringent and they recommend lowering elevated phosphate levels towards the normal range of 2.5 to 4.5. And that's a really low bar for us. What are your thoughts about this?
So I think early the issue of deferring guidelines is also contributing to the problem that we have as practitioners. So we really need to sit down and have uniform goals when it comes to management, because this diversity of goals affects our ability to deliver the care. So I'll take on from here um, that we really have been dealing with the basic three approaches to managing hyperphosphatemia. One we're familiar with is reducing the phosphorus intake in the diet, and by this we really need to focus on inorganic phosphate in additives. We really do not want to restrict the organic phosphate from most nutritional elements, but focusing really on the inorganic phosphate from additives is a key goal of this intervention. Certainly, managing the adequacy of dialysis is important. We manage this not just for phosphate management, but certainly for other electrolytes and the clearance. So most of our patients are compliant with the thrice weekly dialysis program. And then another key element is the phosphate binders that have been the only therapeutic intervention we've had. And you can see, from the 1990s until the 2014, when the ferric citrate was approved, is when we had the biggest development process. And then really since 2014, we have had no additions in the binder sphere. The phosphate binders bind phosphate in the small intestine and produce a insoluble complex that pass through the GI tracts and eliminated in the stool, but they do not target or act on phosphorus absorption pathways. Then they simply bind the dietary phosphorus in the GI tract. The half-life is short in that they act when their intestinal content has phosphate in it, and therefore we need to take this with each meal, makes them more difficult to comply with. Again, due to the short duration of action and limited binding capacity per each pill, the binding mechanism often requires large tablet sizes. The tablet size depends on the type of compound you're using. We need to dose it multiple times a day, so they have to be taken around the meal. And this imposes a very large number of pills on the patient, that average of 10.8 pills a day, which accounts for about half or more of the number of pills our dialysis patients take each day. If you look at here in a graph format, the mean number of medications taken per patient on dialysis is about 12.3, but some of them taking 20 or more, which is a very, very high bar for these patients that have multiple comorbidities. But again, phosphate binders contribute to about half the total daily pill burden for dialysis patients. Um, this is again a big imposition on patients that must be taking large pills multiple times a day and have to be timed with meals. Um, from this, it's not difficult to understand that 62% of patients were not adherent to phosphate binders for multiple reasons, and they may not be adherent never, but they're not adherent intermittently enough to affect the management of hyperphosphatemia.
Thank you. You're absolutely right. The phosphate binder compliance in patients with end-stage kidney disease is really very poor. 62, I have heard statistics of 78% globally that patients do not adhere to phosphorus binders. So you can see that patients really have a variety of complaints during their trajectory with chronic kidney disease. Includes hyperphosphatemia, high blood pressure, diabetes medications, high cholesterol, and depression. And patients actually prioritize which medications, which pills they have to take, because as you said, they take almost 10 to 12 pills per day. And they prioritize the medications that they take for high blood pressure and diabetes management and high cholesterol over those that they need to take for phosphorus binders. They seem to not think that that's so important. And you can see on this slide that depression really is very important in our dialysis patients. And they really care about how they feel. High blood pressure medications, diabetes medications, etc., are very high on their lists. And so, depression medications are the number one pills that people really worry about taking on dialysis. And as you can see, phosphorus is really on the lower end of the scale. And the perceived compliance versus self-reported compliance across medical conditions and the number of pills and injections per day, really the phosphate binders are on the lower end of the list. And what you could see again, this is important. Do they consider phosphorus binders medications, and are they important in their overall lifestyle? And the answer is no. They do not think that they are. They really value medications that change the diseases that led them to having chronic kidney disease, like diabetes and hypertension, as we said before. Again, when you in many cohorts and patients who report less than 100% compliance with their medications, the number one reason they forget to take their medications is the number one reason, followed by too many pills to take. Again, as we said, the large size of pills. They forget to take the medications with them when they go and eat their meals outside. The gastrointestinal effects are really important, as are the unpleasant taste and aftertaste. There's also a social issue to this as well. Patients feel embarrassed to take their pills in a social situation. For instance, when they're out to dinner, and many patients really report that they're really too expensive to take. And if you ask them to take two, they'll prioritize. Maybe they will take only one of those medications. And that really is a problem. There are some new medications, and I'm wondering if we could review those formulations for phosphorus binders.
Thank you, Dr. Kilaporis. Yes, as you see here to the left, we do have numerous phosphate binders. As Dr. Carona said, that not a lot's happened in recent years. Most recently, we did come up with oxylanthanum carbonate, which tends to be a really effective binder, uh, and it is actually a relatively small pill, which makes it a little bit more tolerable for patients. However, they're still taking a lot of pills per day, has been mentioned. And as you can see to the right, you can see the overall volume of these pills. And again, probably Savalomar being the most commonly used pill has the greatest amount of volume. So clearly we are struggling. And again, this pill burden in the issues that have been brought up by my two colleagues earlier really affects how well these patients take it. And if you think to yourself, how well would you be? I mean, one thing I do is I train my fellows is I make them taste every phosphate binder. I mean, a lot of medications we give patients we can't try, but I actually make my fellows taste these so they know what they're dealing with their patients. Well, what about a new approach in order to treat this? And we now have the medicine tenapanor. And as pointed out earlier by Dr. Pergola, again, phosphate binders work and they bind phosphate to the GI lumen and then it passes through the gut. But the primary way of absorption of phosphates was called the paracellular pathway. And what you have is you have the cells, the gastrointestinal cells next to each other, and there's a tight junction. Well, tenapanor works by stimulating the sodium hydrogen exchanger number 3. And by doing that, it actually blocks the sodium from going into the cell and it blocks hydrogen from coming out of the cell. So it increases the acidity of the cell just a tad bit. And that causes the tight junctions to close. And when those tight junction close, you then block the primary pathway of phosphate absorption. So you don't need a binder to get the phosphate to go through the GI tract. They just goes through because you blocked the permeability or the primary pathway of how phosphate's absorbed. Now, one of the things it does increase the sodium just a little bit in the GI lumen, and that could result in a little bit more fluid. And again, it may cause a little bit of loosening of the stools because of that. Well, we now have several studies that have looked at this. This right here is the Amplify study, which is a phase 3 study that actually looked at tenapanor in phosphate binders when used in combination. The primary endpoint was a change in baseline of the serum phosphate at week 4 between tenapanor plus the binder or placebo plus the binder. And then we had secondary endpoints that looked at how many patients achieved a serum phosphate of less than 5.5. The other thing we looked at was changes in FGF23, which we know is a real problem that's driven by serum phosphate. And FGF23 has its own uh, morbidity effects to patients. And then finally, we looked at the change in serum phosphate at weeks 1, 2, and 3. So we had a 2-week run-in period where patients were on their drugs and they had to have a serum phosphate greater than 5.5 while they were on their binders. They were then randomized 1-to-1 to either get the tenapanor 30 milligrams twice a day or a tenapanor or a placebo plus their phosphate binder. And again, the tenapanor doesn't have to be taken with meals. So if you look here at the results, and again, this is the primary endpoint that we were looking at, was compared with treatment binders alone, tenapanor significantly reduced the serum phosphate. And I think what's impressive, you can see within 1 week, you see a rather significant reduction in the serum phosphate, and that persisted during the 4 weeks of the study. So to summarize in the Amplify study, patients on a stable dose of binders with uncontrolled serum phosphate, and again, that was levels between 5.5 and less than 10, tenapanor significantly reduced serum phosphate concentration from baseline with a decrease of 0.84 to 1.21 milligrams per deciliter compared to the binder, which is 0.14 to 0.21. A larger proportion of patients, about 37 to 49% receiving the tenapanor and binder received the goal phosphate of less than 5.5 compared to binder alone, which is 18 to 24%. Of real importance to me, I think, is that you had significantly greater reductions in FGF23 with tenapanor plus the binder compared with the tenapanor alone. And again, we know FGF23 is associated both with cardiovascular risk and not cardiovascular death. Tenapanor was generally well tolerated with no serious adverse events or deaths reported in the trial. And as a unique non-phosphate binding mechanism of action, tenapanor offers a potential management option for reducing serum phosphate concentration and can be used as a dual approach with binders. Well, we now have another study, the Optimize study. This was a randomized open label study It actually had two parts. The first part was a 10-week study. Then we had a 16-week extension study. Patients were on hemodialysis and peritoneal dialysis. And of note, the proportion of patients on peritoneal dialysis was very similar to what we see in the population, about 10%. During the 10-week period, patients on phosphate binders that had phosphate between 5.5 and 10 were randomized 1 to 1. They were either switched from the phosphate binder to tenapanor, or they had their phosphate binder reduced by about 50% of the tenapanor added. We did have some patients that were phosphate binder naive and had phosphates greater than 4.5 and less than 10, and they were treated with the tenapanor. I just want to point out the reason we use 10 as the upper limit of normal is that we wanted to just make sure what we could get here. And as you can see, that the patients who were on the straight switch, 34.4% of them had their serum phosphate less than 5.5, with a mean reduction of 0.91. And of note, what was pointed out earlier by my colleagues is the pill burden was significantly decreased from 9 pills to 4 pills a day. Those that had the binder reduction, uh, they had a 38.2% had a phosphate less than 5.5, with uh, their 9.99 reduction in serum phosphate and a reduction of 9 to 6 pills per day. And those who are binder naive, 63% of them had a serum phosphate of less than 5.5, with a phosphate reduction of 0.87. So I turn it over to Pablo for cases.
Thank you, looks great. And we want to illustrate some of the cases that we felt would be relevant to this conversation. And I think this one hopefully is one that you're all very familiar with, because I think it'll illustrate a patient that we all frequently see. This is I'm presenting a 64-year-old male with end-stage kidney disease due to diabetes, on in-center hemodialysis for about 8 years, who continues to struggle with chronic hyperphosphatemia. The past medical history includes hypertension, diabetes, coronary disease. This patient already has been revascularized, anemia, osteoarthritis, and importantly, depression and secondary hyperparathyroidism. And in the case I'm presenting, the patient has hypoalbuminemia. So high pill burden for multiple comorbidities, and established secondary hyperparathyroidism, and struggles with maintaining goal albumin. The relevant current medications include sevelamer carbonate. Patients prescribed 3 tablets 3 times a day with meals. Calcium carbonate was added in the evening because of hypocalcemia. Patient has, as I mentioned, hyperparathyroidism requiring senecalcid at the dose of 90 milligrams per day. Patient has GI symptoms and has been given omeprazole and takes lactulose as needed for the constipation. Has a serum phosphate that runs between 6 and 6.8 milligrams per deciliter, calcium of 8.6 milligrams per deciliter, and as I said, albumin is now 3.5 grams per deciliter. The patient describes increasing frustration with high pill burden and persistent GI side effects, which negatively affect his appetite, nutritional intake, and overall quality of life. Escalating sevelamer therapy has been limited by the tolerability, and conversation with the patient is healed. This is pretty much the max he can tolerate. And describes poor appetite and reduced food tolerance that further complicate efforts to maintain adequate nutritional intake and the serum albumin levels.
Thank you very much, Pablo. My case is also something that is very commonly seen in my dialysis unit. The patient I'm going to present is a 55-year-old African American male with end-stage kidney disease, stage 5, secondary to type 2 diabetes mellitus. He has recently started hemodialysis, and starting hemodialysis really turns everybody's life around. He's depressed about this. His past medical history is one of end-stage kidney disease, type 2 diabetes, hypertension, and hyperlipidemia. He's on insulin, losartan 100 milligrams per day for blood pressure control, and pravastatin for 40 milligrams daily for high cholesterol. His social history is very relevant here. He's a 20-year pack day smoker, but he quit 1 year ago. But he's retired. He lives alone. And, he's not able to prep his own meals. And it's very difficult for him to really have 3 meals a day that are nutritious meals. And he leads a very sedentary lifestyle. So, as recommended by the KDIGO guidelines, both the 2017 and the updated guidelines, you have been measuring, and I've been measuring his calcium and phosphate levels. This is one of my patients every 3 months. And what I've noticed is that his phosphate levels are persistently elevated, and his calcium levels, though, are normal. So, this really brings to mind the difficulty that patients have obtaining nutritious foods to eat in chronic kidney disease. And there are recommendations for dietary and nutrient intake according to chronic kidney disease stage. And really, when we focused on phosphorus, early on in CKD, minimizing phosphate intake less than 1,000 milligrams. And as disease progresses, the intake of phosphorus decreases to 800. And really, what's important about this slide is that it really talks about two types of foods. It talks about natural foods and foods that contain inorganic phosphorus and preservatives and phosphate. What we want patients to have is really that we encourage consumption of more plant-based foods rather than processed foods. And this is particularly important as they go progress in the CKD trajectory to dialysis. And asking them to minimize their phosphorus intake is really asking them to decrease protein and other foods that are really very important for building muscle. So it really is difficult, and it causes nutrition, malnutrition, inflammation syndrome in our patients, and it's very, very difficult really to address. In my patient, and he lives in a um, underprivileged area in the city of Philadelphia. I've been taking care of him for 5 years. His social determinants of health are really very important and impact his ability to obtain nutritious food. And when I asked to review his food diary, which he brought it in, he said he had a very high intake of non nutritive phosphorus foods. He ate mainly fast foods that were highly processed, frozen foods because the frozen preservatives are sodium phosphate containing, and his housing and food insecurity were major contributors. Social services agencies and personal relationships with patients, really their doctors and their community we need to really encourage that to allow for a safe environment and shared information. And despite dietary manifest modifications aimed to decrease phosphate intake, his serum phosphorus levels remained elevated. I went over his diet intensively, and he said, I can't afford to buy fresh fruits and vegetables and fresh meat. So I eat processed food because that's the only food I have an opportunity to buy. So consequently, his phosphorus level remains elevated, and now he needs to start a phosphorus binder. 3 months later, fast forward, his serum phosphorus is still high with the phosphorus binder. Phosphorus is 6.8. His serum parathyroid hormone is high. We talked about secondary hyperparathyroidism. And he was really very honest with me. He said, I just can't buy fresh food. I can't tolerate the pills. They're too big. The pills are too big for me. You prescribe 2 or 3 with each meal. I'm unable to take them. His phosphorus remained elevated. I want to now turn it over to Dr. Sprague for case number 3.
Thank you, Dr. Kurkors. So right here, we have a 65-year-old woman who has a past medical history of idiopathic membranous GN. She was ANA negative, her hepatitis were negative. She was originally diagnosed in 1996 via biopsy, at which time she had CKD stage 5. She subsequently, some 20 years later, had a subtotal parathyroidectomy for hypercalcemia with 3.5 glands removed. Her parathyroid hormone initially decreased significantly, as we see, from 560 to 25, but then it did creep back up to about 150. Calcium remained relatively normal, but her phosphorus continued to be elevated. In December 2020, she was started on sevelamer, one with each meal, which was increased to 2 a month later, and she was subsequently started in dialysis in February. So this was all pre-starting dialysis. She shortly thereafter developed multiple lesions on her left breast, abdomen, and thigh. So when she was evaluated by me, which was initially in April of 2021, she was feeling okay, but she had pain at sites of her lesions. Was taking tramadol. Her energy was low. Again, as I mentioned, she had a lesion in her left breast, left lower abdomen, and thigh. She described initially as hard lumps. However, they subsequently became open sores that were not healing. She had been on warfarin since 2018 for plaques, which was changed to apixaban shortly before she saw me. She had been tolerating dialysis as well, though recently started. She did complain of dyspnea, mild exertion. Otherwise, didn't have any other gross symptoms. Her medications include allopurinol, apixaban, EPO, tramadol, mycophenolate, metoprolol, herbicide, and sevelamer. On physical exam, again, she was obese, but no distress. Basically, her breasts had hard, lumpy subcutaneous and subdermal lesions with the left breast quadrant, the right medial breast quadrant. And then she had a quarter-sized wound with an eschar in her left breast. Her lungs were essentially clear. She was doing dialysis via a catheter. Her heart was unremarkable. Her abdomen, again, was mildly obese, and then there was a porta-sized lesion in the left upper and a larger lesion in the left lower quadrant. She also had a lesion on her left upper buttocks. Didn't have any, uh, did have some edema. Shown here are her labs over the couple months before she saw me. Again, she had just recently started dialysis. You can see her calcium was relatively well controlled. Her phosphorus was running a bit high. Her parathyroid hormone level was also a bit on the higher side. Her vitamin D level was very low. And as you can see here are pictures of a couple of lesions she had, which are classic calciphylaxis type lesions that she developed. And I think in large part, this was driven by her long-standing hyperphosphatemia associated with the previous hyperparathyroidism and relatively high serum calciums. So the key takeaways here is that hyperphosphatemia increases mortality and reduces quality of life in patients with dialysis-dependent chronic kidney disease. Managing phosphate levels should start with optimizing diet and emphasizing nutritive sources of phosphorus. Phosphate binders effectively manage hyperphosphatemia but are associated with some GI side effects and high pill burdens. Non-binder therapies like tenapanor may be a solution for these patients, especially those with persistent hyperphosphatemia.
This is an excellent discussion. Thank you, Dr. Pergola. Thank you, Dr. Sprague. Thank you to the audience. I think this is a really very important clinical concern for our patients. So thank you, everybody, for your participation.